The next presenter is Dr. Stuti Shah, and her paper is on combined corneal wavefront guided transepithelial PRK plus CXL. The presenter after that is Dr. Jayashree. So are you ready, Stuti?
Yes, ma'am.
Yeah. Please start the timer.
Good afternoon. My topic for today is combined corneal wavefront guided transepithelial PRK with CXL in mild to moderate keratoconus Indian patients. No financial interest. So we very well know that keratoconus is a most common primary ectasia, and it causes corneal thinning and protrusion of the thinned part of the cornea. So management of keratoconus involves inhibiting the ectatic progression as well as visual rehabilitation. So when a patient comes to us, we need to have a holistic approach. Corneal collagen cross-linking as of now is the only treatment available to inhibit the disease progression. But now the buzzword is something called CXL plus, wherein refractive surgery is done along with CXL. So there's a lot of literature in which they have done topography-guided PRK with CXL simultaneously or sequentially, and they have tried to study the stability of the disease and progression of the keratoconus. In all of these cases, basically a surface ablation is done, and after that CXL helps in increasing the biomechanical strength of the cornea. In our study, we have done a corneal wavefront guided study on the Schwein MRS 500E platform. So the primary aim was to evaluate the visual and refractive outcome by doing this procedure. We have targeted mainly only the higher order aberrations, and the secondary outcome was to study the stabilization of the disease. So it was a prospective interventional study where 35 eyes of 31 patients had been studied in a tertiary eye hospital over a period of 1 year. Our inclusion criteria were progressive keratoconus of grade 1 to 3 with thinnest corneal pachy such that a residual stromal depth of more than 400 microns was obtained, and the logMAR CDVA was worse than 0. Exclusion criteria was any other previous ocular trauma or systemic or ocular conditions which would affect the disease progression, or patients who did not give us consent. So preoperative evaluation included corrected and uncorrected distance visual acuity, the anterior slit lamp examination, the topography scans were done. This is a representative image of a patient showing keratoconus, and the wavefront scans were taken, wherein higher order aberrations and coma both are visible to be raised, and after that the fundus evaluation was done and the specular microscopy. So this is how the platform appears, where in the corneal wavefront mode all the data was entered and trans PRK was performed. The custom ablation manager itself targets only the higher order aberrations and tries to minimize the ablation depth, and finally gives us this summary with the ablation profile. It shows us the maximum ablation which is going to be performed. So the data was then put into the Schwein MRS platform, and the PRK was performed. It was a myopic hyperopic ablation, wherein at the cone the myopic ablation was done and a compensatory superior hyperopic ablation was performed. The optical zone was kept as 8 millimeters. After that, the C3R was performed using the Dresden's protocol. The post-operatively antibiotic steroid drops were given, and on post-op day 5, the BCL was removed after epithelial healing. Follow-up data was taken at 1, 3, 6, and 12 months as shown in the table. So our results were that the mean age group was 20.16 years, 61% of the patients were males, and 54 microns was the mean ablation depth. There was no significant change in mean endothelial cell density. Uncorrected visual acuity had improved, however it was not a significant change that was seen. The best corrected visual acuity went from a significant 0.4 to 0.27 logMAR, which was a significant change. Maximum keratometry went down from 50.43 to 48.18, which was again a significant difference. Keratometric astigmatism also went down from 5.48 to 3.17, again significant. So did the manifest cylinder that the patient experienced, that is minus 2.5 to minus 1.65. More importantly, the higher order aberrations which we had been targeting. So the coma values went down from a 1.76 to 0.48. Trefoil also from 0.91 to 0.39, statistically significant. Root mean square values went down from a whopping 2.17 to 0.68. And the spherical aberrations also came down from 0.28 to 0.09. Again, statistically significant. So we could see that how this is the post-op image, and you can compare and see how the corneal surface has been regularized, and the higher order aberrations as well as the coma have come down, so did the trefoil. So in our study, we could see that there was a significant gain in BCVA and corneal regularity, significant decrease in higher order aberrations, and thus a better visual acuity was obtained mainly because of the decrease in coma. There was no progression noted over our study period of 1 year, and there was a significant decrease in manifest cylinder, which was comparable to other studies like the Gore et al. And Shaheen et al. We targeted only the higher order aberrations, so no secondary tissue removal was done for the induced ferrocylindrical changes, and ablation depth was also comparable to the Athens protocol. So in conclusion, corneal wavefront-guided transepithelial PRK is effective in minimizing the higher-order aberrations and thus provides good visual rehabilitation. CXL increases the biomechanical strength. However, we need long-term data. We need to have a comparative study, and patient perception also needs to be recorded in a better format. Thank you.
So, what is different from other studies, Stuti, that you have shown in yours?
So compared to other studies, what they have done is they've used the topography guided model more commonly, wherein the keratometry, surface keratometry is used. Whereas in wavefront guided mode, what we are doing is we are targeting mainly the higher order aberrations. And also in other studies, they tend to either decrease the optical zone in order to minimize the ablation, because mainly in keratoconus, it's an ectatic disorder. We don't want to ablate too much of the tissue. So in this, we are targeting only the higher order aberrations. In that way, some amount of tissue needs to be ablated is also lesser. And our theory is that even if we don't get a good uncorrected distance visual acuity, the BCVA is better, and we can always give the patient spectacles or any other format later on.